Hello, good day to you. I am Dr. LIYANAGAMA. I am attached to a coronary care unit in a private hospital in Sri Lanka, Colombo. I have been working in the coronary care unit for more than 20 years, so that with my experience, I thought of explaining to you regarding ECGs. Today I am going to teach you how the P wave occurs and the PR segment occurs, where the repolarization of the P wave is in the ECG. So before starting, we should realize how the ECG is documented on the ECG paper. So we connect the patient to right arm, left upper arm and the left leg, and all the leads we get collected together, and with the help of the amplifier we amplify the wave, because it's a very small wave current. So that we amplify it and we get the positive and negative currents, and we connect it to the needle where you have a ink. Earlier there were ink. So supposing it's easier for you to understand if you think that ink is fulfilled here, so that whenever you get the current, if the current is above the horizontal line, then you get a positive wave. If the current go away from the horizontal line, then you get a negative wave. But this happens if the ECG paper is in still position, straight upward or straight down. But you know the ECG paper is moving. So if it moves from this direction to this direction, then the wave should have occurred like this. But as the paper moves toward this, it curves like this. That's why on the ECG paper, you get the wave curved, because ECG paper tracing is moving, not in still position. And in the body, where the heart is there, you should know the location of the leads. Now if the heart is located like this, directly downwards you get the AVF, because the foot, F represents the foot is in down, so you get the downward wave in AVF. The horizontal one is lead 1, and on the both sides of the AVF you get lead 2 and lead 3 here, and AVL is you connect to the left upper arm, so that AVL represents the left upper arm, so that AVL is located this side, and right upper arm you connect the leads here. So AVR, arm is right, upper arm is located in this direction. We normally put the V1 also here, this side. Now if you analyze the current, it starts from SA node and it travels everywhere, this side, that side and this side, directly downwards. So both of these currents, they go to the opposite direction. The A current and the C current are opposed to each other, so they will become 0. Then the mean current is left behind towards the B side. So the mean current is B side, so we call the vector is towards the B side. If you see here, the B side is, B current is located towards the lead 2. So axis is, the vector mean wave is towards the lead 2 in atrial contraction. And then if you see the ventricular contraction, also the same, current comes here, then it goes on both direction and downwards as well. So this side current, if you see A, and this side current C, both of these currents are opposed to each other, so that they will become 0. Then the mean current vector is left behind with the B towards the B area. So if you see the diagram here, the ventricular contraction current is towards your lead 2. So in both atria and ventricular contraction, the mean current is located in the lead 2, towards the lead 2. So that is why you get the highest height of the R wave in lead 2. You call it in the normal axis. So in your ECG, the highest R wave should be located in lead 2 when you take 1, 2 and 3. Supposing if the highest R wave is located in lead 1. So lead 1 is, that means that from the normal axis it has shifted towards the left upper arm. So as it's going towards the left side, you call it left axis deviation. In left axis deviation, you should have the maximum height of the R wave in lead 1. Similarly, if the maximum height of the R wave has shifted to lead 3, that means from the normal axis, instead of having the maximum height of the R wave in lead 2, if you get the maximum height of the R wave in lead 3, that means it has shifted to the here right upper limb. So that means the axis has shifted to the right axis. You call it right axis deviation. With this simple method, you can judge what the axis is. If it is the maximum height of the R wave is lead 2, that is the normal axis. If the maximum height of the R wave is lead 3, that is the right axis deviation. If the maximum height of the R wave is in lead 1, then that is the left axis deviation. So if you see the mean current is towards this, and all these leads situated here from here downwards are positive because they are towards the mean value. So in lead AVL, lead 1, lead 2, AVF and lead 3, in all these leads, the wave should be positive. So P wave is positive. In QRS complex, maximum height of the R wave is positive and the T wave is positive. In QRS there are two negative waves are there, Q and S. I will explain to you what the mechanism to occur those two waves when I am explaining the contraction of the ventricles in my next lecture. So likewise, the opposite side from this line onwards or downwards in all the leads, you get positive waves. On the opposite side, that means AVR and V1 you place here, you get as the vector current, mean current goes towards this side, away from that side is negative. So in AVR and V1 you get a negative P wave normally, and instead of R wave, while the QR is contracting, you should get a negative wave normally in AVR and V1, and the repolarization of ventricles, that is the T wave, but that is positive because the contraction moves towards this side and the repolarization moves towards again opposite side, and that repolarization means negative current. Negative current is going towards the negative side. This is the positive side, then the negative side, then also you get a positive wave. Because usually people say when the current comes towards the electrode, then it should produce a positive wave. But that is wrong, because with that theory you can't explain why T wave becomes positive. If the current is going away from the electrode, then it has to be a negative wave. But you know the T wave is positive. So you should know the proper way of explaining. If a positive current comes towards the positive electrode, then you produce a positive wave. Or if a negative current goes towards the negative side, then also you get a positive wave, not the negative wave. Positive to positive and negative to negative, same ions going towards the same electrode, then you get a positive wave. If you want to know about it thoroughly, you can watch my previous E.C.G. In that my previous E.C.G. I have explained how the positive and negative waves are formed in E.C.Gs. If you subscribe, then you get all the list of the videos, then you can choose that video and watch that. Now we will see how the P wave is formed while the contraction of the atrium. Now atria starts contracting from the while the SA node sends an impulse, electrical impulse. It starts with a small area. SA node is situated on the right atria. So first it contracts only the right atrial, some small area. Hypothetically, we will think, for the easier to explanation, we will think that this amount of cells will produce a current of 5 millivolt. Now in ECG, now this is the AV node, so it doesn't go up to the AV node, so the AV node separately I have drawn here to explain, and the ECG tracing I have drawn here. This is the zero horizontal line, isoelectric line. Below that is the negative, so above is 5, 10, 15, 20. Likewise I have notified to explain easier. So as this wave starts from here, it should actually go up, because if it is 5, hypothetically we think that it's a 5 millivolt current they produce with this small contraction area. It should go up to the 5. But it should go straight up if the ECG tracing is in still position. The ECG machine, in the ECG machine, it moves. So instead of going up, when it moves towards this side, it tries to curve. So in ECG, you get a curved wave instead of the straight upward wave. Now next section, now this area already got contracted, so all the negative ions became positive. So now this part is now positively polarized. Now that current spreads towards the other section. Now instead of the right atrium, now it spreads to the left atrium as well. So now huge amount of atria is getting contracted. As the area is bigger, almost 3 times this, so we hypothetically we will think that if this is 5, now this is 15 millivolt current it will produce. Now from the first part, it came up to the 5, level of 5, and now hypothetically I told you it is 15. So with this 5 and this 15, totally it should reach up to the 20 millivolt current. So it should go up like this, straightforward. But as the ECG tracing is moving here, it tends to curve. So the next wave would be like this and curve. And after depolarization of this part, all this part will become now positively charged, and left behind is only small area. Now this area is smaller than this, so hypothetically we will think that it will produce only as the area is small, number of cells are getting contracted are small, hence you get only a 10 millivolt current is produced. So now what should happen is that it should go up, the positive wave, because of the positive wave it should go up by 10. So that means it should reach the 30. But as the total current is 10, but it should not go up to the 30th level, it should come up to the 10th level. I told you the hypothetical, if the area is small, we assume the current is lesser than this area, so that it should come to the 10th level. So instead of going up, it goes down to the 10th level. And as the ECG tracing is moving, rather than going downwards, it tends to get bended. So it will produce a bended current towards this side, coming down. Though it is coming down, it is not a negative current, it is situated above the zero line, horizontal line, isoelectric line. So it is still positive, though it is coming down. It comes down because of the total number of current is 10, so it should reach the 10th level rather than going up, because if it is going up, it should go up to the 30th level. As the total amount is 10, it should come down actually, not going up. That's why after the peak, the P wave tends to bend downwards. And at the same time, this depolarization wave touches the AV node. In these two areas, still it is away from the AV node. There's no current has reached up to the AV node. Now once the current reaches to the AV node, inside the AV node also, it starts depolarization. But the AV node is a very small area. The current being produced by the node is very minimal. So with the high amount of current being produced by the atria, this current is actually hidden inside that wave. Inside the P wave, this current is, this is the representation of the nodal contraction within the node, but the contraction is there, but it is hidden within this high amount of current. So you won't see it. Now the next level is, only this part is left behind to contract in atria. So all this area has now become positively charged, and only this area is contracted. So in the A node, now the current has reached up to A to B, it went in the last, this part. Now from B to C, it moves, but though it moves from B to C, there's no wave is produced because of the contraction of the atria. Now atria current is now very small area, so hypothetically we will think that it is a 5 millivolt current being produced by contracting the small area. So now earlier it was the 10th level, now it is the 5. So it has to go up, but if it goes up, then from 10 it will go up to 15. So total current should be 5, then actually it should not go up, it should go down. Though it is going down, it is not a negative wave, it is still the positive, because this is the horizontal line, above anything is positive. As the total amount of current is being produced is lesser, so it should tend to downwards rather than going upwards. So as the ECG, it should go down like this, but as the ECG tracing is moving towards, it tends to produce a curved wave. So in this section, this part is also contracted. Now the total atria is in refractory period because fully contracted, and all the atrial muscle has become positively charged. So it doesn't respond to any stimulus. So now the current has become, there's no movement of the current now. So it is zero. Current is being produced by the atria are zero. So in the node, now it came up to the A to B and B to C. It came up to C. Now C to D till the end part of the atria, AV node, the current moves. Now there's no current moving in this area. So actually in the ECG, this movement of the current should show. But as I have told you, the AV node is a very small area, and out of that also up to this part, around 70% of the node is contracted already. Only a 20 to 30% is left behind. So that out of that small part, also just contracting at 20% or 30%, the current being produced is not getting detected by our machines. They are not that much sensitive enough. So the machine thinks there's no movement of the current. So again, it will produce a zero line, horizontal line, isometric line. It continues, and this area, because the atria has already contracted, and then it should after the contraction of the atria, still you have a zero line, but during this time, you get the AV node contraction, but doesn't show up because of the small amount of current being produced and our machines are not sensitive enough to detect that current. So in the ECG, after the fully contraction of the atria, the P wave, you get another horizontal line. So that is why you call after the P wave, you get a PR segment as a horizontal line, isolated line. So during this time, there's no current is being produced. And after that, now the atria starts becoming repolarized. Now current starts becoming negatively charged from here to here to here to here to and towards that side. It goes negatively charged wave flows from here to here. But now the problem is, now I told you it reached up to this current reached up to this level, so now it enters to the his bundle. Once it enters to the his bundle, the ventricles getting contracted. As the number of the wall is very thick in ventricles, the number of cells are high. Now number of the amplitude being produced by the contraction of the ventricles are very high, so that it will produce a very higher wave QRS, and during the QRS downwards contraction, you get the repolarization. Contraction already occurred, now the repolarization of the atria also. And as the current is lesser here and the current is bigger amount here, this small amount of current is hidden inside the QRS complex being produced due to the contraction of the ventricle. So during this QRS complex, you actually get the repolarization wave of the atria. So it is hidden there. As the QRS complex is higher, we don't see it. But sometimes in pathology, you can see that wave after the QRS complex, so somewhere here, likewise. I will explain to you that when the pathology of the atria is explained. So this is how the P wave is produced and how the PR segment is produced, and repolarization of the P wave, which is hidden inside the QRS complex, is produced. Now this is the theory of the mechanism, how the P wave occurred and how it curves. So in my next video, I will explain to you how the ventricles contracts and the QRS produce, and depolarization of the ST segment, how it occurs horizontal line, and depolarization of the ventricles, how it produces the T wave. And following that, we will discuss the in diseases, how the P wave varies, how the QRS complex varies in infarction, and likewise. So if this lecture was useful to you, just make a comment or put a like button and subscribe the channel so that you can get notified when I publish my next video regarding how the QRS complex is produced, the mechanism how it produces. So till that time, thank you for watching.